Hey everyone, welcome to my Day in the Life series here on White Coats and Corgis. Most of you probably know me from Instagram or TikTok, where I make helpful free content for pre-meds and talk about my journey as a first-generation medical student. My mission here on YouTube is to give pre-med students all the information they need for a career in medicine. So in order to do that, I've teamed up with MedSchoolCoach to create this series where I'm going to do a deep dive on each medical specialty. And I want to start off by saying that it can be really difficult to accumulate the number of shadowing hours you really need to be accepted into medical school. And especially nowadays, this can be really challenging. A lot of physicians aren't open to shadowing opportunities in person the way that they were before. So that is why MedSchoolCoach decided to collaborate with over 20 doctors to give you a behind-the-scenes look at practically every specialty that you might be interested in. And this is all completely free. You can go to shadowing.medschoolcoach.com, register for the program, and then you get to choose whichever specialties you're interested in to shadow. At the end, you can fill out a short quiz, and then they'll give you a certificate of completion. That way you can count these hours on your medical school application.
So this is obviously a very distilled version of what a day in the life of a pathologist is. Can vary depending on your practice type, academic versus private practice, large teaching hospital versus some sort of community hospital, and also the type of pathologist. So forensic versus surgical pathologist versus a cytopathologist. There are also people who practice primarily a subspecialty, like neuropathology or renal pathology. I'll go over a little bit more of a surgical pathologist day. So this is the most common type of practice in pathology. And this is basically a physician who diagnoses mostly tissue from surgical patients. So biopsies, surgical resections. So a surgical pathologist spends a lot of their day at the microscope examining patient material. During surgeries in which the team or the surgeon needs some sort of histologic diagnosis, they send us tissue, which is then processed by the pathology and histology lab. And some pathologists will either oversee or participate in what's called grossing. So that's where we look at the tissue macroscopically, so not under the microscope, to be able to glean information regarding the diagnosis. And determine what parts of the tissue actually need to be submitted and reviewed by a pathologist. So once the slides are ready, we as the pathologist review the patient's clinical information. We look at all their imaging, all their labs, and then examine the slides under the microscope. And then sometimes we can come to a diagnosis immediately. Sometimes we need to order additional tests. Molecular testing, for example, is becoming ever more prevalent and important in our diagnosis. And then we render a diagnosis as well as a detailed pathology report. If there's something unusual or unexpected for the case, or we need more clinical information, then we will call the clinical team, the ordering physician, or if the imaging doesn't seem to match up with what we're seeing, we'll call the radiologist to discuss further. If we're on call for what we call intraoperative consultations, then the day can be admixed with being in the surgical pathology lab, actually reading what we call frozen sections. So if while a surgeon is operating, they feel they need more urgent macroscopic or microscopic information to determine the next steps of the surgery, they'll then request what's called an intraoperative consultation, also what we call a frozen section. So they'll send us a small representative portion of the lesional tissue, and we do a rapid form of processing. And then we try to address whatever question that they have. It can range from wanting to know if they do in fact have enough lesional tissue. Are they in the actual lesion versus normal tissue? Do we have enough tissue to do molecular testing or to render our own diagnosis? Or do they want an actual diagnosis in order to determine how to surgically proceed? So frozen sections for us are high pressure. They're much harder for us to interpret because the processing is usually suboptimal, very rapid compared to our normal processing. And we try to do this very rapidly because the patient is under anesthesia. And we try to minimize as much time and exposure to anesthesia. So a common example of an IOC or an intraoperative consultation in my field is when a neurosurgeon will ask whether Am I actually in brain tissue or brain tumor tissue? Am I in lesional tissue versus normal brain? Or is this neoplastic tissue like a glioma or a brain tumor versus reactive brain tissue, which is a brain that is normal, but it's reacting to some sort of injurious result? So if we diagnose a tissue as glioma, the surgeon will then proceed to resect it. But if we call it reactive, they'll leave it in. So you can see that's a lot of pressure for us to be able to get the diagnosis right. We don't want to incorrectly call the tissue neoplastic or glioma and for the surgeon to then resect normal tissue. So frozen sections are a big part of our day if we're on call for that and can be pretty high pressure. Other parts of the day include attending conferences. We have consensus conferences. We show our difficult cases to other pathologists. We also have multidisciplinary tumor boards where we meet with radiologists, surgeons, oncologists, a variety of other physicians from other specialties to be able to discuss current cases and treatment plans. We also attend grand rounds, journal clubs, and all of this depends on if your practice environment is, for example, an academic or a large hospital. One of the common misconceptions is that pathologists are more basic science and don't interact with people. But we actually play an immense and direct role in clinical care, as I alluded to previously. Our diagnoses are essential to being able to form treatment plans. And some pathologists actually even do procedures. Cytopathologist, a branch of pathology, actually does, in some institutions, fine needle aspiration procedures on on patients. And there's actually another branch of pathology called clinical pathology, in which the pathologist has an integral role in a large majority of the hospital tests and procedures. So they assure the quality of all the lab tests in the hospital, to managing the entire blood supply for the institution, assessing transfusion reactions. We're also constantly interacting and collaborating with other pathologists, surgeons, oncologists, physicians from other specialties, all trying to deliver high quality patient care. So we're often called the doctor's doctor because we interface largely with other physicians. But I think this incorrectly belies the direct impact we have on patient care. We're a doctor's doctor, but we're also the patient's doctor as well. So I've alluded to this on the last slide, but there are two main branches of pathology: anatomic and clinical pathology. So simply put, anatomic pathologists study organs and tissue, while clinical pathologists typically work with body fluids, blood, CSF, urine. Anatomic pathologists usually practice in hospitals, university, medical centers, independent laboratories, and they work closely with other physicians in order to collect the tissue. So just like we talked about, a neurosurgeon would collect the tissue and we would examine it. They render a tissue diagnosis and then also perform autopsies, amongst obviously a whole host of other responsibilities. Clinical pathologists oversee a whole range of laboratory divisions and services, including hematology, immunology, toxicology, obviously not limited to that. And they oversee and interpret the fluid samples like blood and spinal fluid, bone marrow. Most pathologists, depending on their training track, can practice both. You can have the most traditional training path is the APCP, so anatomic pathology and clinical pathology training, where you do 2 years of anatomic pathology, 2 years of clinical pathology. At the end, you're board certified or you are eligible to sit for your exams and become board certified in both anatomic and clinical pathology. So those are typically, your exposure to those rotations are usually interspersed over 4 years, but essentially you get 2 years of exposure to anatomic, 2 years exposure to clinical. You can do anatomic or clinical pathology alone, and if you do one of those tracks, then it's 3 years. And you can do an AP-NP combined residency and fellowship track. A lot of specialties, not just pathology, are looking a little bit more at shortening training. And so for people who definitely know what they want to do in terms of fellowship, they can do these advanced sort of fast tracks to fellowship. So this is actually what I did, where I did 2 years of anatomic pathology residency, and then sort of fast tracked into neuropathology fellowship, which is also 2 years. Out of all of these residency trainings, you can come out and you can either go straight into practice, you sit for your boards and become licensed, or you can go into fellowship. And fellowship in pathology, there's a whole host of different fellowships, neuropathology, renal pathology, uropathology, almost anything you can think, hematopathology. And the fellowships range from 1 to 2 years. So neuropathology is one of the 2-year fellowships. Most of them are going to be 1-year fellowships. So a lot of different options in terms of tailoring what's your interest in pathology. For our case history, so we have a 52-year-old woman with a history of chronic lymphocytic leukemia, status post a bone marrow transplant. She was admitted for complaints of rapidly worsening confusion, memory loss, concerns for encephalopathy due to possible opportunistic infection. Her daughter is accompanying her on presentation, says she's been like this for about a week, possibly even longer. Really no previous complaints, no history of prior cognitive complaints. No, a lot of these current cognitive concerns predated any changes in her medications, no other neurologic symptoms, no reported fevers. So in her review of systems, she does endorse some fatigue, photophobia or sensitivity to light, constant headache, some generalized achiness and dry skin. Her past medical history, she obviously has the CLL, status post a bone marrow transplant, fibromyalgia, migraine, pulmonary aspergillosis, which is an opportunistic infection that immunosuppressed patients can have, history of seizures as a child. Her family history was unremarkable. She, in terms of social history, works as a waitress, divorced, and has 2 children, and does smoke but denies alcohol or drugs. So these are her medications. So there's obviously a lot of medications. So I pointed out just some of the ones that are a little bit more pertinent for us. So she is on tacrolimus and prednisone. So these are immunosuppressants. Since she had the bone marrow transplant, she has to take medications in order to suppress her immune system so it doesn't attack the donor bone marrow. And then she's on a whole host of medications to help prevent opportunistic infections. So levaquin is an antibiotic, acyclovir is an antiviral, voriconazole is an antifungal, and then Bactrim is an antibiotic. So in terms of her physical exam, her vital signs look stable. Her neurologic exam shows that she's alert, but main finding is she's encephalopathic, meaning she's confused, she's inattentive. That can be suggestive of some sort of more widespread general process in the brain. All the other, what we call focal signs, are negative. So focal signs let us know where, particularly in the central nervous system, we might have a problem. So nothing else giving us really a clue as to specifically what's going on. Her blood work showed that some of the cell counts, white blood cells and platelets, were low, consistent with the patient having a history of bone marrow disorder, the CLL. And because of the suppressed immune system in this patient, an infection was suspected, and the patient was tested for many usual and unusual infectious agents. So what we see here in terms of all of these tests, so Coxsackie, Ehrlichia, HIV, you can see that it was a whole panoply of both viral, fungal, and bacterial tests. When there is any sort of suspected infection of the brain, it's more helpful to directly sample the fluid that bathes the brain, the CSF or cerebrospinal fluid. So this can be obtained by what's called a lumbar puncture, which is a pretty routine procedure. They pass a needle through the lower back, and the fluid can then be drained directly. So that's the fluid that bathes the brain. In this case, the CSF showed a massive and abnormal immune activation, as if there was an infection. However, testing the spinal fluid directly for the causes of infection, so you can see here we did a lot of these same tests, VZV, HSV, CMV, a lot of these same tests on the actual cerebrospinal fluid. And all of those were negative. So a clinical pathologist would actually oversee the conduct of all of these tests, the blood tests, and then especially the CSF. A cytopathologist would actually review the CSF, look for immune cells there if there's an abnormal increase in immune cells or even cancer cells. And then they would visualize that under a microscope to see what clues they can find. So in this case, this served to exclude some unusual causes like cancer. So imaging was done, an MRI of the brain with and without contrast. So an MRI of the brain obviously provides a detailed look at the structural changes going on inside the skull, since we can't see that just by examining a patient. In this case, there were two important findings that gave additional clues to explain what was happening to this patient. The MRI finding showed a surprising finding for her age. There were multiple strokes throughout the brain. So we see here new changes of acute infarct, which is a stroke, in parts of the white matter, and then parts of the cortex. So that's fairly unusual for this age of patient. So in terms of her hospital course, so she was admitted and all of these tests were done. She was immediately started on antibiotics and antifungal therapies for a presumed infection. Initially had some improvement in her symptoms. We also tapered her steroids. Steroids, as I mentioned, are an immunosuppressant, and when you have an infection, you obviously don't want to suppress the immune system. Despite this, her neurologic status deteriorated, and so at that point, neurosurgery was consulted and a stereotactic brain biopsy was obtained. So stereotactic referring to image guidance that helps locate exactly where the lesional tissue is. So this is the first stereotactic biopsy. And this is what we get as a pathologist. So we obviously get the added benefit of a microscope, which allows us a lot more tactile motion of the tissue and being able to increase up and down into the plane of the tissue. So this is a very static image. So this is a histologic image of a section of gray matter in the brain. This is taken at high magnification and stained with hematoxylin and eosin, which is the main tissue stain that we use as pathologists. So the hematoxylin is the purple right here. And this stains primarily nucleic acids, so it's used to illustrate nuclear detail in cells. So anything purple is likely cell nuclei. Eosin stains pink, so you see all the background pink, and that stains primarily proteins. So this is used to highlight the cytoplasm of cells. Here we see a huge background of pink, and all of this is in the brain what we call neuropil. This is the dense network of glial and neuronal processes that help make up the gray matter of the central nervous system. So the purple we see here right here are cell nuclei, and this is a mix of primarily neurons and glial cells, which are the supportive cells of the central nervous system. And typically the neuropil is much tighter, much more densely pink, without all these holes and white spaces. The appearance is what we call microvacuolation and is suggestive of a whole host of possible processes, but most commonly edema or brain swelling. We also see what we call reactive astrocytes. So as pathologists, we train ourselves to learn how to detect what morphologies are suggestive of a particular cell type. What's a neuron? What's an astrocyte? When we see astrocytes become activated because of some sort of injurious result, they become more prominent. We call this reactive astrocytosis, and they start becoming, their cell nuclei start becoming more irregular in shape and larger. So, all this basically told us was there was some swelling in the brain and some sort of injurious insult to the brain. So we did some staining. So this is a GMS stain. This helps highlight microorganisms, particularly fungi. Typically, any microorganisms would show up grayish brown. Here we see there's no definitive staining. A lot of this brownish material is actually just background non-specific staining. So this was actually negative for any microorganisms. So this is what in an abbreviated format, a typical pathology report would look like. It's a little bit more elaborate, but I've culled it down just a little bit. So we always note where the specimen or the tissue is from, so the cerebrum, so the brain, and then what the procedure was, the stereotactic biopsy, and then we list in order of the most important what the final diagnosis was. So we see here there was necrosis or death of tissue, brain swelling, known as edema, and then the reactive astrocytosis, and we really didn't find any infectious cause. And remember, we're presuming infection based on her clinical picture. So given that she deteriorated, they ordered a second stereotactic biopsy. So sometimes we might not get an area on the biopsy that actually has the representative pathology. Sometimes the pathology can be very spotty, so they may need to go back and get additional tissue, which is what they did this time. So you see here, this is predominantly pink, so not very much nucleic acid, suggesting not very many cells. So this is all basically dead material. This is dead brain tissue. And if we look a little bit closer, is a lot of pattern recognition. We can see some highlighted organisms somewhat. You can see some sort of almost like branching organisms. So this is a little bit higher magnification. And you can see here, this is somewhat unusual. This doesn't look like normal cells in the brain. So these are broad fungal or hyphal structures. They are somewhat irregular, and they seem to branch at sort of almost a 45-degree angle. And then they don't have any septations, or what we call compartments. A lot of these, what we call morphologic features or characteristics that we see under the microscope, can help us sometimes determine what type of microorganism this is. So we can tell this is a fungus. It looks a lot like a fungus, but we can't tell specifically what type of fungus. So this is, again, that GMS stain that stains for microorganisms. And you can see now how well highlighted the organisms are. You see the background staining, but then you see the very prominent sort of grayish brown staining with these hyphal structures. So fungus has this sort of elongated structures. When we look at mold as opposed to bacteria, most bacteria are going to be very small. These are very large structures. I think bacteria would be more on the order of some of these little purple dots in terms of size. And then viruses, we wouldn't really be able to see. Those something you would have to either do electron microscopy. So the fact that these are large, and it's like I said, the morphology, so the physical appearance of these that suggests that it's a fungus. So nothing else really looks like this.
I see.
So and that's all of pathology, is very much pattern recognition. So this is the pathology report for that second stereotactic biopsy. So this was necrotic tissue. Couldn't really call it brain tissue because there actually wasn't any brain tissue on the slide. And this was a biopsy from the arachnoid matter, which is the covering of the brain, and some of the pericarotid tissue. So some of the tissue that was surrounding the carotid arteries in the brain. This time we did in fact make a diagnosis. So this was indeed an infection with a causal organism being a fungus. Oftentimes we also want to add more detailed information than just the final diagnosis. Pathology reports tend to be much longer than this, particularly if it's a complicated case. So if we want to convey more information to the clinical team, we then put a comment in. And here we note that we couldn't reliably identify the specific genus of the fungus on histology and morphology alone. So the clinical team will then need to, or the ordering physician will need to correlate our histologic findings with the cultures. So unfortunately, the patient did pass away. So the hospital team and the family requested an autopsy to further elucidate the etiology of her death. And so obviously an anatomic pathologist performed the autopsy. So if anybody's squeamish, the next few slides are going to have some what we call gross images, macroscopic images of the brain. So this is a gross or macroscopic image of the ventral or the undersurface of the brain. You can see the olfactory nerves right here, optic chiasm. You can see the brainstem, basilar artery. These are the temporal lobes, and this is the cerebellum. And so typically all these structures in this are very visible, very translucent, but we can see this area is completely opacified due to fibrosis and scarring. But there's also an organizing, purulent or pus-filled exudate enrobing the basilar artery. So right here, usually you can see these structures delineated very nicely. And in this case, you can see all of this opacification. We also see evidence of what we call uncal herniation. So these two structures right here are sort of the tips of the unci, or the tips of the temporal lobes of the brain. So when the brain swells, this causes increased intracranial pressure, which then causes abnormal protrusion of brain tissue through the openings in the rigid skull. So this can cut off blood supply to essential portions of the brain and is essentially fatal if you don't reverse it. So we can kind of see here, typically this is a little bit more of a normal temporal lobe. You can see it's kind of nice and full, and here we have a notch. So it's starting to hit a rigid portion of the intracranial structure. And we also see evidence of tonsillar herniation, with a portion of the cerebellum possibly herniating through the foramen magnum, or opening at the base of the skull. So the tonsils of the cerebellum are right here. And if they are starting to swell and then be pushed down into the foramen magnum, you start to get sort of protrusion of this part of the cerebellum called the cerebellar tonsil. So this can be obviously a very life-threatening situation, and was obviously in this case. So these are coronal sections of the brain. So coronal referring to crown, which are cuts of the brain in the frontal plane. So if we think of a crown, you're kind of going from anterior to posterior, front to back. And I like to compare this to how we would slice a loaf of bread almost. So we can see here that this obviously is not healthy brain. We can see this central portion right here is not very well delineated. Usually these structures are beautiful, very well, very crisp and well defined. But you can see here it's almost cheesy and looks like it's going to fall apart. So this is likely necrotic brain tissue and represents an involving rhinocerebritis. So this is inflammation following a tract that likely began from the nasal cavities. So this particular fungus has an extreme propensity for what we call angioinvasion, meaning it invades, spreads, and then extends via vessels. And therefore we can see tissue destruction along a particular anatomic vascular tract. Here we see an infarct involving the anterior cerebral artery, extending into what we call the lenticulostriate vessels and the structures that those vessels perfuse, specifically the basal ganglia. So all of these structures you usually are able to see very clearly, very well on gross examination, but here you can see that it's pretty much all obliterated. So then as the autopsy pathologists, representative sections of the areas that were pathologic are taken and processed. So this is a very high magnification image of actually a vessel. So this is the lumen of the vessel. If you were to take a vessel lengthwise and then cut it along its length, this is what it would look like. So this is typically where blood would flow. This is the vessel wall. This is all what should be brain tissue, but it's actually necrotic tissue or dead tissue. And all of these are those organisms that we saw earlier crawling and extending onto the vessels. And this is how they travel and this is how they invade. So this is called angioinvasion. A little bit higher power just shows the vessel wall, vessel lumen, necrotic tissue, and you can kind of see how they're basically crawling along the vessel into the brain tissue that it's now already destroyed. So we see a slightly lower power view here. So we're a little bit more zoomed out. We see predominantly necrotic material. So this is all this pink. You can see not very much purple. We'll talk about the little purple that we see right there. But so this is predominantly necrotic material and also a sea of inflammatory cells. So in the upper portion of this is all inflammatory cells. These are in particular macrophages, which their sole job is to engulf organisms. So this is called necrotizing granulomatous inflammation and is a very common inflammatory response to fungal infection anywhere in the body. In necrotizing granulomatous inflammation, we often see what's called multinucleated giant cells, or cells which are basically activated macrophages that then become enlarged and then contain multiple nuclei. So we can see a few scattered here. So this big one right here and this one right here, that's actually just one macrophage. So that's a multinucleated giant cell, and you can see multiple nuclei just in that one cell. And then you can see the fungus right here. So this is a little bit higher power view so you can see the necrotic material, all of the macrophages, and these multinucleated giant cells. And you can actually see in this one giant cell, it's actively engulfing the fungal hyphae right there. And if we go to another view, you can actually see a really nice view of this particular multinucleated giant cell engulfing this portion of fungus, and a little bit higher power view. Just because it's a very striking image. I will say that this is obviously, I selected this case because it was a very interesting case, a very representative case, also highlights a lot of what pathologists do. We both do autopsy and surgical specimens, as well as if you're a clinical pathologist, then you look at CSF and lab tests. But this is also a very just striking case in terms of the histologic appearance. So we don't usually get images like this where you can actually see the macrophages engulfing the hyphae. We also have to generate what's called a cause of death. So this is what the autopsy pathologist suspected was the primary cause of death. This is incredibly important, both in how we word our cause of death for medical legal purposes. Autopsy reports, just like anything in the medical chart, can be used in medical malpractice or medical negligence cases, or even criminal cases. And so it's also important for us, in terms of being able to come to an accurate diagnosis, to be able to give closure, and also pertinent clinical information for the family. Sometimes if there's some sort of genetic underpinning for why the patient died, that's important for families, or just the knowledge of what actually happened to my loved one can be important. So in this very sad case, the cause of death was swelling and herniation of the brain due to fungal infection causing inflammation of the brain. The meninges, which is the covering of the brain, and also the ventricles. And then underlying this was her immunocompromised state due to her CLL and her bone marrow transplant. So all of these had a causative role in her death. So just a little bit about the fungal infection that caused her death. So this was, the particular fungal infection was identified to be mucormycosis, which is caused by fungi in the zygomycetes phylum. So these are organisms that are fairly ubiquitous in nature, in general, very common in the environment. You can see them in soil and decaying vegetable matter. And they grow rapidly and release large numbers of spores that can become airborne. So most of us and most humans are exposed to these organisms on a daily or weekly basis. They rarely cause disease because of the low virulence of the organism, and our immune systems can handle it. But they can cause very severe disease in immunocompromised patients, such as this patient, and in those with very specific risk factors.